Hi viewers, greetings from Penang International Dental College. Welcome to Penang International Dental College PIDC webinar series. PIDC webinar series is a part of Penang International Dental College's commitment to imparting holistic dental education even beyond classroom settings. And for this purpose, we have been organizing a series of web events on varied topics of interest. And if you can go to our website, pidc.edu.my, you can see a lot of activities we have done in the past. For today, we are presenting a webcast called Expert Opinion on the topic of mouth cancer in conjunction to Mouth Cancer Awareness Week 2020. And today I'm accompanied by my colleague, Dr. Larry. Hi, Dr. Larry.
Hello.
And we are very privileged to have with us a guest who is not only an academician par excellence, but a very humble human being. And Dr. Lari, for our new viewers and students, can you tell us who our guest is today?
Yes, indeed, of course. Thank you so much, Dr. Fawaz. We are indeed very fortunate, and it's my privilege to let you all know that we have with us today none other than Professor Dr. W.M. Tilakaratne. Professor Tilak, as we all know him, is a renowned speaker and a scholar, and someone whose name is almost synonymous with research in oral cancer and oral potentially malignant disorders. To me, myself, he's been a mentor and a guide. And thank you so much, sir, for joining us today. So, good afternoon to you, sir. And I would like to begin with asking you a simple question. So, can you tell us how your journey has been from where you began to where you are right now?
Well, good afternoon, everybody, wherever you are. Larry, first let me thank Penang Dental College for inviting me to talk on a subject that is very close to my heart, oral cancer. The question that you ask, my journey to reach who I am today, it was, I would say, not a better process. That path was difficult at times. But I had the courage and determination to become a better pathologist one day. This is not a few years or 1 or 2 decades story. I wanted to become a pathologist, who I had very keen interest towards oral pathology and pathology in general when I was a student. When I was a student also, that was one of my favorite subjects, if not the most favorite. So I used to look at the slides and enjoy them, while my batchmates and my friends didn't like much the subject of pathology. Right? For most people, when you are clinically trained, pathology is not the most interesting field. But I had that motivation from my student days. And then soon after graduation, we are talking about now almost 3 decades ago, so I joined the Department of Oral Pathology in the Faculty of Dental Sciences at University of Peradeniya, the only dental school for the entire country. And then from there, although I had the desire to become a pathologist, we did not have postgraduate studies in pathology, right? But I did not give up my idea just because we don't have oral pathology postgraduate programs in Sri Lanka. So I opted to do, because as a junior lecturer, you need to do postgraduate during a stipulated time frame during your probation period. So I opted to do oral surgery postgraduate degree. and which I completed, and then I left to UK for my further studies. So that is, I had some basic background and knowledge in oral pathology when I arrived in London. But my pathology base, mostly my foundation was laid there. So I need to mention who helped me to go there. One of our former deans and my mentor, Dr. Ajit W. Ranasinghe. And he sent me to the appropriate place. That is also those students who are watching this live. It's very important for you to be with the correct people at the correct place at the correct time. So if all those things click together, I think you can't go wrong. In that sense, I was fortunate, and I was sent to one of the best oral pathologists I have seen, my mentor, Prof. Peter Morgan. He has nurtured not only me, another very eminent, one of the best oral pathologists in the world, Eddie Odell. He was his first trainee, I was his second trainee, Peter Morgan. So I learned from very basic to advanced head and neck pathology from him. So I had the courage because my time was too short, because I was enrolled in oral surgery post-surgery program, so I didn't have significant exposure. So I had spent long hours during my oral pathology training at Guy's Hospital, London, before King's College. So I used to spend late nights, sometimes till 12 o'clock in the department, right? Going through all the slides, the archival materials, etc., etc. For that, I think that determination and courage and the enthusiasm, I think, paid off. So I did because of my surgery background, I did my fellowship at Royal College of Surgeons. On the same year, I went there, and then I entered into the pathology training program of Royal College of Pathologists, and I got my diploma and membership, and later on FRC PAN. Now, it is such a coincidence for the youngsters who are listening. I'm telling this. Now, I think, probably about 25 years ago, I think, I was asked to present a paper at IOP, International Association of Oral Pathologists, which was held in Cape Town, South Africa. Right? I went there with Professor Kosem, that you all know, the old dental, Professor Kosem, myself, Professor Odell, and Professor Morgan, we all went for that meeting. That was my first IOP meeting. On that day, I never thought exactly after 20 years of getting membership, I would become the president of that august body, which I did. So that's again due to our commitment and dedication towards the subject. So all the time, whenever there is a meeting, there is a conference, we always tried, as youngsters, try to gather more and more knowledge in order to become a better pathologist. Because the pathology is not something you gain with manual dexterity or manual skills. So you need to read, you need to gather a lot of theory knowledge. So that we did as a youngster, even up to now, we used to do that. Now, how I came to the field of research is again interesting. My very first research paper is on oral submucous fibrosis. About little more than 2.5 decades ago. Right? The grading epithelial dysplasia in oral submucous fibrosis under my professor, then Professor B.R.R. Mendes. So that was my first paper. But again, during that time, I never realized that I was going to become a little better researcher in the field of oral submucous fibrosis. So now I'm happy to say that our group is one of the largest groups of oral submucous fibrosis research. When I came back to Sri Lanka after all my postgraduate studies, etc., that was about 21 years ago. Our facilities at Peradeniya was very good because we had a brand new dental school when I came back uh, as a donation from the government of Japan with all the facilities which I had even at Guy's Hospital. And so I was lucky, right? I was lucky. So I managed to start and completely develop the existing pathology at that time in my department to a different level. Right? So, and we went on to start the 5-year postgraduate degree program in MD oral pathology. Now, few batches are qualified already. My research from oral submucous fibrosis, then I went on to extend that to oral cancer. And today, I think we have understood some aspects of both OPMDs or potentially malignant disorders and oral cancer, but still there is a long way to go. Especially in the case of submucous fibrosis, you know, the millions of people are suffering from this disease in South Asia mostly, and also to some extent in Southeast Asia, including Malaysia. So that is where the younger generation should embark on research. Now we, together with our the collaborators, have explained the pathogenesis, pathways of pathogenesis, pathways of malignant transmission, etc. But now the younger generation of people, that is their responsibility and duty to embark on further research in order to identify a treatment for this deadly disease with a lot of morbidity, especially, and also mortality, uh, especially affected by poor people in South Asia. So that is the task for the younger generation. But still, we have a lot of things that we don't know. We need to understand. We need to research and identify. We'll talk about cancer with the questions, especially in oral cancer as well. And so that's basically my journey. Of course, from the oral pathology administration point of view, of course, starting as a member and then the Council for Asia, then President, Assistant President. So I never missed any of the IOP meetings unless I have some other very specific commitment. And of course, I went into administration and became the dean of the only dental faculty in Sri Lanka from 2015 to 2018. I think that is what Larry, we contributed to the field of pathology by writing chapters in very many books and also publishing textbook as well.
Right. So, thank you so much, sir, for that. So, may I now pass on to Dr. Fawaz? Want to ask us something?
Sir, I'm going to ask you, I'm very curious to know that during sir's initial life as an undergraduate student and choosing oral pathology as a specialty where others were choosing prosthodontics and orthodontics, what kind of support did you get from your parents or from your peers who helped you in your initial days to shape up your career? When were you struggling at all during your initial years? I would like to know that part of period which shaped your destiny.
Actually, that's interesting. I don't think my parents, my father died when I was very young. And my mother has never asked what kind of field or anything. All what she knew was I was doing dentistry. And my elder brother, like my father, he was always asking me what kind of things I'm doing field. Although he also didn't have much idea about the field of dentistry. So, yeah, I think I would say it's the destiny. I think I was, my fate says probably you are going to become a pathologist. So, we are, otherwise, not many people in the world, when you have an opportunity to practice as a surgeon by doing the postgraduate in that area, leaving that behind and to become a pathologist.
Yes, sir.
But I, for whatever the reason, when I saw the great pathologists, the medical pathologists during my days, my younger days, when I looked at them, especially in the medical faculty, there was a great personality. Uh, when I look at them, I thought I also should become a pathologist one day, but I knew oral pathology was not a field that people knew that time, even our own medical colleagues, the medical students for that matter. So when I started my postgraduate also, there was no recognition to the subject of oral pathology in Sri Lanka. So that is why I said at the beginning, my journey of oral pathology is not a path of the better process. So I had to overcome a lot of obstacles, etc. Of course, I had help and guidance from various people, my teachers, mentors. But it is the sheer courage and enthusiasm and the commitment to do something better, to achieve something better. That kind of sheer self-motivation, I think, took me where I am today. Yeah, that's a very good question. A lot of people ask when they meet me, especially those people who knew I was doing surgery as a postgraduate training. Any particular reason why you changed? No, that is the reason for success. You should not do your postgraduate or whatever just because others are doing, just because somebody is doing well. Now you need to talk to yourself and you need to ask yourself whether you are going to be happy, whether you can achieve something, whether you can do something new, whether you can do something substantial to the people of the world. That kind of self-motivated questions you have to ask yourself. I think that will give you the courage and determination to try. So I probably that is what my motivation was. But my mentor, I told you, Dr. Ajit Ranasinghe, he from the inception was motivating me to become a pathologist, and he was the force behind forcing and motivating me to sit for a master path, etc. You need to have somebody in your life to encourage. Actually, my wife, of course, she's the professor of periodontology now. So my batchmate, so she was a pillar of strength. So whenever I need any advice, I could look for her, and vice versa. So we complemented each other to shape up our careers. So that is for any youngster that is important. If you can get the help from your mentors, your peers, your spouse, etc., I think that is always a bonus, which I had enough.
I totally agree with sir, because it's just a matter of asking. Most of the students feel shy to ask if some particular faculty can be their mentors, or just reach out to the faculty. I think the take-home message is, I mean, sir has rightly said, you need to have a mentor and you have to be at the right place at the right time.
Correct.
I think it's fantastic. Thank you so much for sharing that, sir. Just coming back to the oral cancer, I just wanted to know that oral cancer has different geographic distribution. For example, oral cancer in Malaysia, the incidence of particular cancer would be different as you find in say UK or in Sri Lanka. Is it true? How is the geographic distribution of oral cancer in this decade?
It's a good question, actually. Yes, oral cancer is a big problem in South Asia and to some extent in some countries in Southeast Asia. It is not a big problem in the West, Americas, etc. That is purely due to the etiological factors. Right? The etiological factors causing oral cancer is very frequent, very common in our part of the world. So therefore, the oral cancer has become a very common problem in Indian subcontinent and also in some countries in Southeast Asia, especially countries like Papua New Guinea. The oral cancer is a very big problem. It is, of course, almost number one ranked cancer in males. Now, it is directly the geographic distribution of oral cancer in the world is directly related to etiology. Now, the etiological factors, now when it comes to oral cancer, the large majority of, before that, let me tell you, the oral cancer we are talking about, the big problem in our part of the world, how big it is, if you say, about 30% of oral cancers occur in Indian subcontinent. So that will tell you the gravity of the problem, and to some extent Southeast Asia. Now, the oral cancers in this part of the world are mostly related to smoke plus tobacco and areca nut. So that is the bitter truth, right? So now these two ingredients are taken in these countries in different ways. Now, when it comes to India and also Sri Lanka, Bangladesh, those countries, the traditional betel quid, right, where they get 4 ingredients mainly together, wrap it in a betel leaf and chew it for hours. So the ingredients: tobacco, areca nut, slake lime, and it is wrapped in the betel leaf. And depending on the country, the geographic area that you are talking about, people add various other things like spices, etc. But those, the main ingredients such as areca nut and tobacco is there in most countries. But again, if you look at countries like Taiwan, where again oral cancer is common, their betel quid does not have tobacco. Right? They have mainly areca nut and other ingredients. Now, because these things are in abundance, oral cancer has become a big problem. If you take, for example, Sri Lanka, the number one ranked cancer in males is oral cancer, not lung cancer. In India, it is lung cancer number one, number two is oral cancer. Right? But when it comes to Malaysia, the oral cancer is far down. It is coming almost close to 20th. Right? So it is not a big problem. That is simply because the etiological factors are not in abundance. And mostly in Malaysia, if you take that is the Indian population, mostly Indian descent population, they use the betel quid, right? Some of them use. So that is why we see the significant number of oral cancer patients here in Malaysia are the Indian ethnic group patients. Right. If you look at another reason why oral cancer is very common in this part of the world is not only due to traditional betel quid, that's also due to the numerous amount of different brands of commercially available areca nut. Right? If you look at India, for example, there are about hundreds of different types of areca, concentrated areca products. It's a very big business. Right? Some of them contain not only areca, it has tobacco as well. So those things are very popular among even youngsters, the school children. Right? So that is why we see it is the emerging trend in this part of the world now to see oral cancer in the young, right, among the young. So that is due to these concentrated areca products. Now, if you remember in the West also, many years ago, the oral cancer started becoming a common problem in young as well. That is due to a different etiological factor. That is due to HPV, right? But that is not pure oral cancer. They are mostly oropharyngeal cancers. But that problem, we don't have to that extent. We don't have the oropharyngeal cancers in abundance like what we experience in the Western Americas. of HPV origin. But not plus tobacco products, other products are also available in this part of the world, as well as they're mostly available in Scandinavian countries, Europe, America, etc. as well. But you need to remember the carcinogenicity of tobacco used in different geographic areas are also different, right? It's also different. Therefore, the cancer, oral cancer that you see in this part of the world, the betel quid-induced oral cancer is a different disease. The youngsters should remember this. It is not the same disease that we are talking about in the West. Non-betel quid-related oral cancer. My colleagues in the West also recognize this. Some people think it is not two diseases. There are many diseases, also we call it oral squamous cell carcinoma. There are different types due to different etiological backgrounds, etc. So that is what we need to understand. So there are a lot of implications because we are talking about the same disease that we see here and in the West. So therefore, you need to remember all these things when we talk about the geographic distribution of oral cancer. It is in summary, it is mainly due to the etiological factors and the distribution of etiological factors available besides the geographic distribution of oral cancer.
Just on the lighter note, sir, I wanted to ask you, India has also been a British colony. Malaysia has also been a British colony. How come they have not taken betel nut and areca along with them to the West? Why are they not using it? They had an access. They could have. I don't know. How is that, sir? Why have they not taken the betel nut and betel leaves from us?
Very interesting question. Actually, I also didn't think about it. But you need to remember, we did not have tobacco, right?
Oh yeah.
We did not have tobacco. Now, to South Asia, who introduced tobacco is Portuguese, right? When, for example, in 1505, Portuguese came to Sri Lanka, right? So then only, the people in that part of the world started using tobacco. Betel quid tree must have been there, but it's only areca nut. Now we have the carcinogens combining together. Yes, I think probably because this is when you look at it, the chewing beetle, the mouth is very red and it's not the most pleasant thing to see, etc. Even by that time, those people who came from the West are probably in a better developed, This I'm just thinking. They didn't want to, I think, probably, have that appearance, etc. Probably, and so they already had the tobacco habits when they came to, when they colonized this part of the world. They had tobacco habits in abundance, all kinds of smoking forms, etc. So I think they had one addictive substance. So therefore, I think they probably didn't have the need for that. Because our people, they probably didn't know those days areca nut is addictive. Now, if you look at psychoactive substances in the world, now it is said the alcohol present in areca nut is the fourth most psychoactive substance, addictive one. After nicotine, alcohol, caffeine, then comes the alcohol in areca nut. So now you can see why people use areca nut, without stopping. I don't know. They probably, actually, some of them must have tried. Probably, I think simply because of the appearance, etc. I think they didn't want to carry on with that, I guess.
So we'll just take a question from one of our viewers who's asking us about molecular research and drug research. It's Arvinda Babu, who's asking you directly whether your opinion regarding level of research he's talking about oral cancer research, and he feels that research is researchers the amount of research done in chemotherapy for oral cancer is much lesser than compared to other cancers of the body. And he's also talking about Western population versus the Asian population, and molecular research and drug research. So what do we have to say?
Hi, Aravind. I know you very well. Yes, it's a very good question actually. I think the entry point to this question is we were talking about whether we are talking about the same disease or two different diseases. As I told you, we are talking about two different diseases, although it's called oral cancer in the West and here. Yes, we all know the treatment of oral cancer, mainly threefold, it's becoming 4 or 5 now: surgery, radiotherapy, and chemotherapy. Now we are talking about immunotherapy. I will just mention about a little bit of immunotherapy. But well, we know the primary treatment, the mainstay of treatment for oral cancer is mostly surgery, supported by radiotherapy, right? The role of curative chemotherapy for oral cancer, the evidence is not clear and not strong enough at all at the moment, right? This year there was a good review in oral oncology where they have looked into this, and it is even more so when it comes to our part of the world. The use of chemotherapy for oral cancer is much less in Indian subcontinent, especially. But in countries like Japan, they do. But role of chemotherapy, basically, if you ask whether it can be used or it is being used as the primary treatment for oral cancer, probably the answer is not, except for the recurrent cases and the metastatic cases, and those cases which have spread all over the body, etc. So in those cases, chemotherapy may have a role to play. But as it is now, the evidence of chemotherapy as a mainstay of treatment for the oral cancer is not great. And especially from our part of the world, the research is minimum, right? We don't have research. Even overall, comparing the chemotherapy alone, various combinations, etc., the research is very less. But that is one area where we need research. But people try not only combination and also the induction chemotherapy for the late stage cancer. Some people think I have tried, but again, we don't have much research. First, treat with chemotherapy and see whether there's a response, and you go on to other treatment as well. But people have been using mostly when it comes to oral cancer, together with radiotherapy, the most frequently used agent is cisplatinum. But the success rate is not great with chemotherapy. But especially as Aravind asked, I think we need more and more research using patients with our kind of etiology, right? So it is a little unfortunate that most of the treatment guidelines that we use are coming from the West, and they are actually mostly based on those patients. And as I have been telling all the time, if it is a different disease, if its behavior is different, whether we are doing the correct thing is the question. Because if you look at the microenvironment, the connective tissue that we see in cancer patients in the background of betel chewing is fibrous, densely fibrous. So the behavior of cancer cells in that fibrous mucosa as opposed to non-fibrous is different. So we know the metastatic rate of oral cancer, especially which occur in the background of oral submucous fibrosis, the deadly disease, is less compared to the non-fibrosis cases, non-submucous fibrosis cases. So likewise, there can be enough differences between these two. So therefore, as Aravinda correctly said, we need comparative studies, including chemotherapy. Mostly chemotherapy was not considered many years ago at all. Now the people started using it, but as I said earlier, it is more like palliative for the recurrent or metastatic disease and very advanced cancer. Not it is never a primary treatment option for, say, the stage 1 or stage 2 early cancer. So the induction chemotherapy, the people are talking about it. I think it needs a lot of research, but it will come one day. And if you want me to elaborate a little bit on other type, the immunotherapy, I think that is the future. I'm very optimistic that the treatment in terms of immunotherapy would come to oral cancer field as well. For various cancers, now people use the clinical trials, take some of them. And even for oral cancer, together with other cancers, of course, there are studies also, few of them. Drugs using against the PD1 and PDL1, right? That is program death protein, one, and also the ligand. Now, if you can inhibit this molecule, I think that you can boost the immune system to kill tumor cells. What happens is the PD1 present in immune cells, the PD1 molecule in immune cells get attached to the PD1 ligand in cancer cells. Once that happens, immune cells cannot perform its function, right? The natural killer cells and all other cells. Now, the protective effect of immune cells against cancer is lost. So now, of course, there are drugs. There are a couple of drugs actually for this. Now, people have tried drugs. Let me get the name. One is the nivolumab, and there's another drug more with the same family. They can inhibit PD1 and PDL1. So therefore, it can boost the immunity. That is some promising area of research. I think we have a Malaysian group, Cancer Research Malaysia also. The group, the Sok Chin's group, they are also working on this. I think immunotherapy is kind of an optimistic future for a lot of cancers.
So I wanted to ask you, sir, for our part of the world, most of the literature is coming from the West. What is holding us back in Southeast Asia when we talk about more cancer research? What is holding us back? I mean, why are we not able to do things at par with the West? Because sir has both the views from the West also and from this part of the world. So what is holding us back? I mean, how would you comment on that? Is there a problem?
I think that is the multifactorial thing, but we need to accept. But people should not think that I'm going to tell us excuses not doing research. But infrastructure and the funding part for high-flown cancer research in this part of the world is not great, right? But if you want to do, actually using even the funding available, there is significant amount, but it is not happening. I think this is probably, I don't know whether I'm wrong telling this. Now we have a habit to look at the West and, stay, till something coming from that part of the world. I think I will say that is also the colonial mentality, right? So the people are not geared to do high-flown research. The funding, of course, is a problem, but the disease burden, especially for clinical staff, the disease burden is more than in the developed part of the world. So therefore, time factor, I agree with them to some extent. But more than that, that is the motivation. I think the motivation to do research in, I think, our part of the world, we are catching up, but it is not great. Now, a lot of people, I think, don't do research with the purpose, with the correct goal, right? So we have to accept the fact that, a significant amount of academics do their research for their promotions, etc. Right? So that is not going to end up anywhere. Now, all what we need is the impact research, right? The impact research, the translation research. Every research that you do should be able to change something. So that is all about impact. Now, you sit down and think, what has changed with my research? As my stakeholders of research have gained something and they have changed their way of life, the pattern of life, the disease pattern, the treatment, whether any of those things have changed due to my research, right? So that is at the end of the day impact. Now, although we do little bits and pieces of research, I think the properly planned research with translational value and impact is, I think, not adequate in this part of the world. I think, again, I have to tell you that now the things are probably the things are catching up, but those the feelings of not funding and we are not the best people to do research, etc. That kind of mentality we need to change. Now, if you look at the developed part of the world, now there are a significant amount of people from this part of the world gone and doing 5-star research. I think the way forward for the people from this part of the world is to start good collaborative projects. That is what the younger generation of people should start. Now, doing something on your own and finishing and ending up with nowhere is not the way forward. I think you need to identify the priorities and get proper collaborators. That is why I said you need to have correct people in correct places at the correct time. So you can identify the people who are good in these particular areas in the rest of the world. And if you communicate with them, now with the information superhighway, it is not difficult for you to identify who are better, who are the best people in that particular field, etc. Now, if the younger generation of people from this part of the world start communicating with them, write to them, not to one, many. The first time you might fail, second time you might fail, keep on writing and try to get a start from somewhere. Try to be part of a good collaborative project. So that is how you can bring good research to this part of the world. Right? So otherwise, always we are talking about, these are different diseases, but we are always adopting the treatment protocols, the guidelines coming from the other part of the world where the etiological factors for oral cancer is totally different. Now those, the guidelines might not work perfectly for our patients. Now if you look at the oral cancer, now whatever said and done, now only 50% of oral cancer patients live 5 years. So that is the reality. And about 70% of oral cancer patients in this part of the world present to clinicians at stage 3 and stage 4. Now, those are not difficult areas where we can improve, right? So, oral cancer is not a hidden cancer. Large majority of cancers, arise from a precancer or oral potentially malignant disorder. The time period to diagnose it, early diagnostic, is even more. And mouth is a place where you all look at day and night. So you can identify. Now you see the preventive programs should focus more on those areas and educate. We know the level of literacy is not the great in some countries in the part of the world. But still, giving this kind of basic information and getting them to practice is not difficult. No meaning of going into tertiary prevention, right? So we need to catch them as primary prevention, secondary prevention, and even better, if we have primordial prevention, right? The primordial prevention means, we completely stop etiological factors coming, right? So you stop cultivating tobacco. You get alternative crops. You stop cultivating arecanut and get alternative things for those people who live on that. Right? That is primordial. Then primary prevention is our tobacco cessation programs, etc. What WHO through FPCT doing a lot of things in different countries. It's happening. And then the early detection, the secondary prevention, it is up to the health professionals. No, it's rather difficult and not cost effective, etc. when it comes to tertiary prevention of oral cancer, especially for the developing part of the world where oral cancer is common. And you need to remember the fact that oral cancer is not a cancer in the affluent society. It is a cancer of the lower socioeconomic classes. Now, if we want to combat this problem, we need to take all these things into consideration, combine them all together. Otherwise, we are always, till we say goodbye to our life, also we'll be talking about, oral cancer is the commonest cancer in this part of the world. So we should be able to stop that slogan. In a near future, in order to do that, I think we need to have better preventive programs, better screening programs, better research, and to get and draw better national guidelines in different countries, the regional guidelines, using patients from this etiological background. So that is the way forward.
Sir, sorry, Dr. Fawaz.
No, I was just saying I agree with Dr. Tilak that we need to have a mental change. We need to think from a different perspective. Otherwise, this is a never-ending story. And like Sir says, in our part of the world, the Southeast Asia, this particular branch is quite open for people to come forward and do something about it. Like, maybe just how Sir stepped into oral pathology long time back. So here we again have that opportunity, and we have mentors like Dr. Tilak available, to nurture these young minds. So I totally agree with Dr. Tilak. Thank you so much for sharing, sir. Dr. Lahari.
Yeah, sir, we have a question from one of the viewer, Mr. Jagat Fernando, who's asking us about khat chewing. Khat is chewing. Khat chewing. KHAT. It's a product again. It's chewing in Africa. And then any information about high incidence of oral cancer in Africa.
Yes, thanks, Jagat. How are you? My long-term friend from UK. Jagat, khat chewing is not practiced in our part of the world. Yeah, that is again, these khat chewers, they come up with the various changes in the oral mucosa. So the khat and tombak and those things are mostly in African countries. I think khat is very common in Yemen, I think. Yeah, they are also leading to the precancerous stages, but luckily they are not in our part of the world. We should pray that those things should not come to our part of the world, because we have enough problems already. Khat chewing can increase the.
But are we aware of the incidence, sir, of oral cancer in Africa? I mean, is it high?
Often I can't tell you, but there are enough papers on khat chewing on the web actually.
Yep. So moving on, Dr. Fawaz, you would like to take a question from Mr. Mukhtar?
Yes, sir. Mr. Mukhtar Kamil would like to ask us that what is the reason for the slow progress of research in oral cancer? Is it low mortality rate? And is oral cancer given not a priority or a second importance? Would Sir like to comment? Because Sir has already spoke about having manpower, having the skill manpower. Sir can add a few words on the question.
No, actually, we discussed this in detail. I don't think what he has is it due to the low mortality rate. No, I don't think it is a disease with low mortality. It has high mortality. I told you already, only 50% of oral cancer patients uh, live 5 years. So that's a very high mortality rate. Uh, so the reason for less cancers, I think less research, of course, we discussed. So I don't need to repeat the same, but what is important is to get teams together rather than doing, individual research, looking at few patients and trying to look at the demographic data and a little bit of other features and try to publish a paper. I think, as I said earlier, you need to find those people who are doing in-depth research, and there are enough people who want to do research, especially in the West as well, because you are rich. This part of the world, you are rich in material. You have enough patients, etc. So getting collaborations with the people from those countries is not a big problem. So I think it is the lack of motivation and desire to do research more than anything else. The funding is difficult actually, given the current time, the COVID era now, this year and the coming few years. I think the money coming to research will be certainly less, but still the available money is more than enough. I think this the oral cancer, we should never think it is a disease with low mortality. Now you need to remember the treatment of oral cancer costs more money than most other cancers in the human body. Now if you look at oral cancer, the resection plus reconstruction with microvascular surgery, etc., will take almost 20 hours for one patient, right? 15 to 20 hours, that's a lot in terms of manpower. If you calculate, that's a huge amount of money. The economic loss is very difficult to be tolerated by the developing poor countries. So therefore, the only way forward is to diagnose them as early as possible. As I told you, the large majority of oral cancer in this part of the world, more than I think 80% or more of oral cancers arise from precancer in this part of the world. So de novo cancers are very little. So therefore, we have enough time. The younger generation of dental surgeons, I encourage you to practice as a habit. Every single patient who comes to you, spend 45 seconds on every patient that you see. Look at all the different sides of the oral cavity. That won't cost much, get much of your time. It's only 40 to 45 seconds, but that will go a long way, right? Because I know when you do a wonderful filling on the right side, if the left side has a little white patch, if you fail to identify that, I think that's a big problem. That I think ethically it is not correct, but that can happen. If you don't embark on and taking a patient as one unit, the holistic approach, rather than taking tooth as a unit in isolation and treating it, so then I don't think we are going to achieve our goal. Therefore, I think dental profession has a huge role to play, right? Almost all these patients come to you one day for some other dental treatment, and most of these cancer patients who had cancers have visited dentists in the past, and probably their dental surgeons have failed or overlooked the presence of precancer. So that can happen, that will happen. I think that is why the younger generation of people should have better motivation. The leaving away a little bit from the mechanistic approach, because the dentists should not become mechanics, right? So you should become more oral physicians, right? So you should look after the whole oral cavity. if you have that mental attitude and mental frame only, you tend to look at the whole mucosa. It is not only the dental heart issues that you need to look after, right? The mechanical aspects are important, but in terms of patients' longevity and the living and their disease-free life, that is the mucosal services that the dentist has to look for, right? So please remember the younger generation of dentists, the students who are listening. That is your prime duty. Every single patient who comes to you, look for a possible OPMD or pre-cancer in the mouth. If you do so, I think oral cancer incidence in this part of the world will be reduced, and at least we will be able to say most patients present at least cancer patients at stage 1 and 2. We need to change the 70% of patients coming at stage 3 and 4 to the other way around. If we can get 70% of them coming in stage 1 and 2, I think the survival, 5-year survival will go up to 80-90%. Now, as it is now, only 5% of oral cancer patients in South Asia present to clinicians at stage 1. Only 5%. That's a very little number, right? So therefore, our dental curricula should pay more attention. The public, the community dentists, etc., more attention to this kind of the aspects to motivate, to get the correct motivation from dental students when they become dentists.
Yes, sir. Even before Dr. Lari takes the next question, I just want to put in a question. Sir has described the role of general dental practitioners in the prevention of oral cancer. Now, most of us who think oral pathologist or pathologist are people who just look into the microscope and just give out a diagnosis or confirm a clinical diagnosis. I want to know, sir, what is the actual role of an oral pathologist or a pathologist in oral cancer? Is he just looking through the microscope and signing a few reports, or is it much more than that? This is a misconception that I am very curious to ask you, sir.
It's much more than that, actually. So I did a separate webinar actually on role of oral pathologists in the management of oral cancer recently to a huge audience. No, it's not. The diagnosis is one thing. Yes, for the surgeon, the most important thing is to get the bottom line diagnosis. But it is not only that. The pathology of the cancer will tell you various other things. It will tell you what specific pathological features are there. And those pathological features are not just there. Those pathological features would predict the prognosis of the patient, and it will give some idea to the clinician as to how nasty the cancer is. Now, most of the pathological criteria that we give to the clinicians can be used to draw the treatment plan. It's not only the bottom line diagnosis. Now, for example, I say we have an oral cancer patient, the incision biopsy is done, the neck is negative clinically. Now, the clinician need to look at various things in order to decide whether he is going to treat the neck or not. Right? The management of end-node neck pathology has a huge role to play. So therefore, the clinician, it is the role of the pathologist to give the clinician whether there is vascular invasion, lymphatic invasion, perineural invasion, right? So, say suppose there is vascular invasion and the node is clinically negative, the neck is clinically negative, but still the chances of having occult metastasis is very high. Anyway, the occult metastasis is up to 20 to 30% in most oral cancers, depending on the site. But that pathological feature, the surgeon can get some idea as to whether he's going to do the neck or not. The depth of invasion, how deep the tumor. Usually, if the depth of invasion is more than 4-5 millimeters, now most clinicians think, it is better to go for an elective neck dissection. the pattern of invasion. If you have discohesive tumor cells at the advance in front of the tumor, then that cancer very well end up in a lymph node much easier than another cancer with very solid nests of tumor. That kind of information is, and the host response, the immune response. A cancer which has a very good immune response will not go into a lymph node very easily compared to a cancer without host response. That kind of information is very important. More importantly, for the adjuvant treatment, the pathologist's role is very important. Now, surgeon expect the pathologist to tell them whether they have resected the whole tumor or not, whether the margins are clear, whether the nodes are clear, whether there is micrometastasis, whether there is extranodal extension. Now, those guidelines will give some guidance for the clinician to go for other adjuvant treatment, like we were talking about chemotherapy and radiotherapy. If there is extranodal extension, now some surgeons might feel, in addition to my surgery, I should give chemoradiation to this patient. Likewise, all the details that we produce in the pathology report will have some benefit, right, to the management or drawing up the treatment plan for a particular patient. I think young surgeons should get that motivation to read the whole report, not the bottom line. But I know some surgeons do that. Read only the bottom line, and in the process missed a lot of very valid, important information that they need to get in order to decide the extent of the surgery and whether they are going to treat the neck or not. I think all that information is there from a pathologist report. So all those histopathological parameters, I think that one needs to look at. The pathologist role does not stop there, even in the role played by the pathologists at MDT meetings, right? Multidisciplinary meetings is exceptionally important, right? The pathologist should help the clinician to draw up the correct treatment plan, right? So that kind of information together with radiologists, etc. Pathologist is not just the bench man sitting and writing something and sending it to the surgeon. It is much more than that.
Yes, thank you so much, sir. Dr. Larry would like to ask a question.
Sir, I would like to pick up a question from one of the viewers here who's asking us, Ashton Chan is asking us about the role of sunlight and UV radiation in as an etiological factor for cancer, oral cancer.
Yeah, that's a risk factor. The sunlight, now this doesn't apply for oral cavity and tongue cancers, but we get sunlight induced probably associated cancers on the lips. But it is a very common cause. In white skin people, we know the basal cell carcinoma is as common as fibrocellular polyps in white populations. So that is induced by UV light, air sunlight. What happens is whenever we expose to UV light, dark skin people are protected due to the melanin, but white skin people are not. So what happens is we get DNA damage. Accumulated DNA damage can lead to carcinogenesis. Now luckily, just because then you might ask why everybody doesn't get cancer. Everybody get exposed to sunlight, sometimes long hours. No, it is not. Once they exposed to sunlight, if you get some UV-induced DNA damage, now in the body we have what is called DNA repair mechanism. Now in the cell cycle, when the cell comes to G1 phase, that is the main checkpoint where when the cell has some DNA damage, with the help of oncosuppressor genes like p53, it induced the DNA repair mechanism. That defected part of the DNA, the strand, is cut off. And that is called the DNA repair mechanism with the help of DNA endonuclease enzymes, etc. Now that process is induced by oncosuppressor genes such as p53. That is why when p53 is mutated, now this process does not take place. So they are more prone to get cancers, right? If it is beyond repair, if the damage is so much then what happens is still you do not necessarily end up with cancer. Again, the p53 gene and various other genes upregulate the process of apoptosis, the programmed cell death. So then that cell which cannot be rehabilitated or repaired is killed by the process of apoptosis. Yes, the UV light, although we get exposed to UV light, there are various protective mechanisms in the human body to protect us. When it comes to oral cancer, pure oral cancers inside the oral cavity or tongue, in those areas, sunlight, UV light is not a factor, but for lip, yes.
Right, sir. Then I think that's all the questions that we have, all the time that we have for all the questions. And I'm glad we've managed to answer most of them. And any last comments, sir, to sum up the whole discussion that we've had in the light of the pandemic? I know we're all, I assume that we're all in our place where we are, and oral cancer research is something which we need to really look into, and then you have motivated us all enough, even the students also who are watching, as well as the young dentists who are watching. So can you sum it up for us, sir, and tell us your last views on this topic?
Yes, my main message is prevention is better than cure. It is even more so when it comes to cancer. It is even more so when it comes to oral cancer. It is the most preventable cancer in the human body. As I alluded to earlier, we can see it very early because oral cavity is a place where we look at all the time. B, large majority of oral cancers occur in the background of oral precancer, which has been there in the oral cavity for long years. Right? So therefore, prevention is better than cure. It is the duty of mostly the dental fraternity, right, to screen them out whenever they come to you, right? If you can't afford to do population screening or the mass screening, at least take it as a duty. Think that is your duty to look at least those patients who are coming to you, right? Screen them thoroughly. If we do that, I think, or if we can screen almost all the patients, a dentist can do that actually. They at least in a few times of life, all these patients visit a dentist. Now, if we can do that, I think we can afford not to do high-flown research, right? As youngsters, if we can at least do that, so we will certainly reduce the prevalence and incidence of oral cancer, especially the etiological factors are identified. If you can motivate these patients against these etiological factors, I think you don't need to look for big money for high-flown research. With your mouth and with little bit of commitment and sacrificing little time from your clinical time, I think we can address a lot of problems. And I think if we do so, in another 10 years or so, we can think the oral cancer is declining from this part of the world. I think younger generation, the involvement of habit is also becoming a little less, I think. If you control these commercially available Lyrica products and the younger generation, the indulging in betel quid traditional habit is less. So I think our future is not that bad in terms of oral cancer prevalence. I'm sure during our lifetime we should be able to see the oral cancer is declining in this part of the world. That is my final message. The prevention is always better than cure.
Dr. Fawaz. Yeah, I think that's it for now from our side. Thank you so much, sir, for joining us. I think Dr. Fawaz would like to say something.
I want to thank Dr. Tilak for taking time off. I think he had a discussion which he kept pending because of our webinar. I'm very thankful to sir for giving us his precious time. Thank you so much, sir, from us, from PIDC, for being with us. Thank you, Dr. Larry, and thank you, viewers. Thank you, viewers, for joining us. And if you would if you're not from PIDC, if you're watching us from India or from Taiwan or from any part of the world, if you want, we do this webcast quite frequently. And if you want to know about our past events and the forthcoming events, you can visit the PIDC website at pidc.edu.my. We have all the list of our activities there, or you can follow us on PIDC Facebook, and so that you can keep getting messages. And we also record the whole program, and it is available on PIDC YouTube PIDC channel. So you can always subscribe to the YouTube channel, and you'll get a notification whenever we upload a video. So that's it from us for now. And we wish you a very safe days ahead. Take care of yourselves and take care of others. Bye-bye from all of us here.
Thank you. Bye-bye.